Hi everyone, thanks Michele for the introduction. Today I will talk you about my work about interplay between social inequalities and COVID-19 spreading in Santiago de Chile. So Santiago is the capital city of Chile and it is home to nearly 7 million people, which is roughly 40% of the total population of Chile. And it is divided into several comunas, which are basically municipalities. And these different municipalities are characterized by profound social inequalities. So simplifying a bit, we go from very wealthy places to much poorer places within the same urban area. The experience of Santiago with COVID-19 and more in general of Chile have been pretty dramatic. So as for many countries in the world. So the first case was identified on the 3rd of March in a traveler from Europe. And then after this date, after a couple of weeks later, on the 16th of March, the first restrictions were imposed. So this means that schools were closed, public gatherings were banned, and passengers from high-risk countries were isolated. But nonetheless, cases soared anyway in the capital city of Chile. And this is why on the 15th of May, a full lockdown was needed and expanded to the whole area of Santiago. So to give you an idea of the magnitude of the outbreak in Santiago, so as of 1st September 2020, in the whole area of Santiago, more cases were reported with respect to, for example, Italy as a country. So this is just to give you an idea that the COVID-19 outbreak in Santiago has been huge, at least in the first wave. So in this work, we aim to use mobile phone data to model the spatial spreading of COVID-19 in the different comunas of Santiago. And we aim to evaluate the interplay between the disease spreading and social disparities. So in this talk, I will go through the dataset, the description, so mobile phone data, how we model the epidemics, and finally, our findings. So let's start from data and modeling. So we use mobile phone data. So mobile phone data comes in many forms, and we use a data stream which is called Extended Details Records, in short XDRs. And basically in XDRs, every time there is a packet request between a mobile device and an antenna, this is recorded. And since the antenna are in specific places, we approximate the position of the individual or of the device with that of the antenna. So we have data from a mobile service provider active in Latin America, which is Telefónica Movistar. And after cleaning, our dataset consists in 1.4 million people, which is roughly 22% of the total population in the area considered. And what we do is that we basically assign a home location to each user, and then we monitor the travels, the trips between the different comunas. So at a glance, this is what happened to the mobility in the urban area of Santiago. So we see that before the 16th of March, mobility is fairly constant and we see a clear weekly pattern. And then after the first restriction on the 16th of March, mobility hugely dropped. And after this date, we see that mobility remains fairly constant. And then after the full lockdown established on the 15th of May, we observe an additional decrease in mobility by around 17%. So beside this general overview, we also compute, for example, what are called mobility networks. So here we have two matrices that correspond to two different mobility networks. And on the rows and on the columns, you have the different comunas in Santiago. And each dot corresponds to a number which express the flow of people between the different comunas. So for each pair, we track the number of people traveling between different comunas. And we do that during what we call the partial lockdown. So this is the period during the first restriction, so after the 16th of March, and during what we call the full lockdown, so after the 15th of May. So what about instead the epidemic modeling? So we model disease progression with compartments, and this is a pretty standard technique in computational epidemiology. So basically, very briefly, individuals are divided into different groups according to their health status. So we have, for example, the susceptible and healthy individual in the S compartment. They can get infected, interacting with the infectious. They transit to the exposed state. They get infectious themselves, and finally, they recover. We also take into account age structure. So we divide individuals into different age groups, looking at the official census, and we also include mobility, of course. And in the next slide, we will see how. But why do we need a model? So why don't we just look at the data instead that we have? So here I'm trying to be a little bit poetic. So when you want a model, you want, for example, to forecast the future or nowcast the present or understand the past. And this is the main reason why we want a mechanicistic, a generative model, to understand the past and to run counterfactual scenarios that can help us to answer questions like what would have happened if. So here instead, how we include mobility in the epidemic model. So our epidemic model looks like something like this. So we have a spatial layer. So each bubble, each gray bubble is a communa, so a municipality. And within each communa, we have the different individuals. They are the colored marbles, and they are colored according to their health status. So the S are the blue, the infectious are the red, and so on. And we see that between the communas, we have bridges that represent mobility. So the flow of people between communas that we monitor and we measure with mobile phone data. And within each communa, we have also a social layer because individuals are organized into different age groups and different age groups mix at different levels. So this is why we have contact matrix to describe the level of contacts between different age groups. So let's go to the findings. So first finding is that communas with a higher human development index became more isolated after the restrictions. So what is the human development index? It's an index, it's a measure of the level of achievement of key aspects of human development. So simplifying a bit, we obtained that wealthier places became more isolated after the establishment of some measures with respect to places with lower HDI. So the welfare place, the less the movement. Second findings regard our model. So how do our model performs? So here on the top, you have a plot that tell us that the model is capturing pretty well the overall trends of the number of weekly deaths in the urban area of Santiago. And instead at the bottom, we have two plots that are telling us that also the spatial pattern of the spreading is well captured and described by our model. We also evaluate the impact of the restrictions. So in the case of Santiago, we observed that the partial lockdown of the 16th of March was actually pretty useful because it slowed a lot the spreading. So here we are plotting RT, which is the reproductive number, which is this measure of how fast the epidemic is growing or decreasing. And we see that while the partial lockdown decreased the RT, it wasn't able to push it below 1, which is this threshold under which the epidemic decreased. But instead, the second lockdown, so the full lockdown, was actually able to push the RT below 1. We also evaluate the impact of the inequalities, and we find that wealthier communas, so communas with higher HDI, experience significantly smaller outbreaks. And reminder, we have seen in two slides before that they were also the communas which became more isolated after the restrictions. And this is something, so the fact that wealthier communas experience smaller outbreaks is something that emerged from the data, but it's also something that emerged naturally from our model, which is just mobility informed and does not know anything about the socio-economic status and structure of the different communas. We also run counterfactual, as I have said before. So basically, we tweak a bit the parameters of the model once it is fitted to try to answer to counterfactuals question like what would have happened if. So for example, we run counterfactuals in which we do not introduce the full lockdown of the 15th of May, and we see that this would have implied around 35% more deaths and definitely more cases. And we also run counterfactual on the timing of the full lockdown. So we move it backward and forward and backward. And we see that also the timing is specifically important. So the earlier, the better, basically. And finally, we also run another counterfactual, which is probably more interesting than the previous one. And I would like to take you this as a mental exercise, because there are a lot of caveats that should be put forward when proposing this counterfactual, but it's still interesting because we answer ourselves this question. So what if everyone in the urban area of Santiago could afford the level of social distancing that we observe for the top 25% of the welfare communes? So we look at the mobility reduction of the top 25% of welfare communes, and we apply this to the whole area of Santiago. And the results are pretty striking, because we observe that the number of deaths and the number of cases dramatically decrease. And what is interesting is also that the top 25% welfare communes benefit from this scenario, because since they are part of a networked system, if their neighbors are less affected, they will also benefit from that. So take-home message. So 2 main points. The first one is that epidemics are complex phenomena, and I guess that we all agree on that, at least now after 2 years in a pandemic, but still they are threshold phenomena. So the case of Santiago is emblematic in this sense, because only the compounded effect of the subsequent measure was enough to contain the spreading. And the second take-home is that while lockdowns are unquestionably useful, they may widen disparities also in terms of health outcomes. So specific policies should be implemented to balance these inequalities. So of course, this is a great teamwork. So huge thanks to my collaborators who gave me the opportunity to work on that and to learn a lot from that. And if you liked it, there is also the paper. So I would invite you to check the paper and read the paper, because there is much more. So thanks a lot for your attention.
Thank you, Nicolò, for the nice presentation. And so we move to the Q&A. And we start with a question from the audience. Right now we know Chile is a place where vaccinations are rolling. There is rolling out, and we know also that there are some issues with in the case of Chile also with the epidemic that is growing. And do you have information about the relationships between the vaccination uptake and the HDI and the wealth of the Comuna of Santiago? And would your approach be able to explore the impact of an heterogeneous uptake across Comuna on the spread of the disease during the vaccination campaign?
Thanks for the question. So regarding the first question, I don't have the data at hand, so I would recommend to check the data, because I am not sure whether actually the uptake correlates with the HDI, for example. This is something that should be checked. But definitely, yes, Chile is also unfortunately extremely interesting for the second wave, and what we have witnessed in the past month, because it was extremely fast in deploying the vaccination, but still the case soared anyway. And definitely this model, this framework can be applied also to describe what happened in the past months, including, of course, the vaccinations. And this is something that actually we are exploring to evaluate the interplay also between the speed of the rollout, the efficacy of the vaccine, but also the speed at which the government or people decided to reduce the adherence to the non-pharmaceutical interventions.
Thank you. And another question, we heard also in the presentation by Caroline Bacchi, another example of study on Chile. So in the end, among countries that are in Latin America, Chile has attracted some attention. Do you think there is a reason, for instance, due to the data availability in this case, and what is the the quality of the data that you were able to use?
Yes, when facing these problems, the data availability is the problem. So in the case of Chile, data, I mean, there is a lot of data. So the mobile, we were lucky enough to get the data from the mobile provider, but also the other kind of data, like for example, the epidemiological data, they are very good. So they have this repository in which they provide a lot of data about from the number of ventilators to the number of cases, deaths, and so on. So maybe this is one reason why it gained attention, because they were extremely open in sharing the data, and the data that they've shared are very rich. Regarding Latin America, yes, probably overall it gained less attention with respect to Europe and US, for example. But yes, definitely, probably data availability is one of the problems.